Thank you so much for that introduction. And I definitely want to vocalize that please feel free to ask questions during the presentation. For me, it's always hard to remember questions to the very end. I always want to get them off my chest. If there's anything that you guys ask about that may be upcoming in the presentation, I'll try and jot down a note of it so that we can come back to talking about your questions at the end. And then one other disclaimer, this is talking about medications and treatment with my presentation. And I did not focus on deep brain stimulation, though if you guys do have questions about that, I'd be happy to talk a little bit about it at the end as well. Okay, so here we go. So the objective that I want to go over with you is to review what Parkinson's symptoms terminology is so that we're all on the same page when we're talking about various Parkinson's symptoms. Review both medication treatment options and non-medication treatment options that are available for these various symptoms. And then as a disclosure, the information that I'm talking to you guys about are not specific medical advice to you. So with your doctor and neurologist, if there are specific questions about why certain medications are being used or why not, each of you has your very own special flavor of Parkinson's that is being managed by your neurologist. So make sure that you take what I talked with you about today, but also put that in perspective to the various other medical conditions you have going on that your doctor is considering. All right, so let's talk about some Parkinson's symptoms. So with Parkinson's, the primary symptom that leads to the diagnosis is Parkinsonism. And that's going to be that cardinal slowness of movement, that bradykinesia that your doctors have probably talked to you about, the slowness of movement that has that irregularity and gets slower and smaller as you try and make the movement. You can't have Parkinson's disease without bradykinesia. So very commonly people will say, oh, the tremor, you need that tremor for Parkinson's disease. And that's not always the case. About 20% of Parkinson's patients don't have tremor. Going along with that slowness of movement, you need one other thing. You need either the rigidity, the rest tremor, or some balance problems to land you into the Parkinsonism, where you have two of those. But these are symptoms that are commonly experienced by patients with Parkinson's. When patients are having more of those Parkinsonism symptoms, we call that an off time. So when your doctors ask you, are you feeling off medication? These are going to be times when medications are not working well, or the Parkinson's symptoms are coming back. So slower movements, less coordinated, feeling more stiff or rigid, having more tremor, having smaller steps, getting stuck while moving, smaller arm swing. These are just some examples of some of the movement problems that can come up when a patient is feeling off. On time is another phrase we like to use when we're treating with medications. These are periods of time where your Parkinson's symptoms improve on medications. So some examples, moving faster, less of those things that go along with the off time. We use the word dyskinesia. Dyskinesia are these extra movements that are slow, writhing, dance-like. They can be these flowing movements that are occurring. It's a sign of advancing Parkinsonism, and I'll kind of go over where we expect to see that in a Parkinson's disease trajectory. It's associated with certain medication use, but I want to clarify it's not caused by taking certain medications. And I'll talk a little bit more on that in a bit. And then there's some non-motor symptoms. So the part of Parkinson's I was talking about before are those motor symptoms that affect how a patient moves, but then there are other non-movement symptoms, things like trouble thinking, hallucinations, depression, anxiety, sleep problems, smell changes, urinary bowel changes, sexual problems, changes in blood pressure. This is not an exhaustive list, but a very common set of features that are present. And just because a patient with Parkinson's disease has Parkinson's disease, it doesn't necessarily mean they're going to experience all of these symptoms. So keeping that in mind, that just because we talk about these things doesn't mean it's something you're definitely going to get into. When we use medications, we like to talk about what kind of symptoms respond to medications, and there's a couple that don't do well with medicines. Those would be some balance problems, swallowing difficulties, and apathy, which is that lack of wanting to do what I want to do or not getting as much enjoyment in doing those things I want to do. So those I tend to talk with patients about. That's really hard to just throw medicines at and treat. So we need to talk about other ways to help get those under control. So this is, yes. Good question.
Can't hear it.
Okay. Yeah.
Can't hear it.
Is there a way to, yeah. Okay. No, not that one.
Yeah.
Yeah. There we go. Okay. It was just a new person joining in. Okay. This. So change this. Okay. So this is a typical timeline of Parkinson's disease. This was published in the New England Journal of Medicine. The time zero is taking in when patients start to develop those motor symptoms, that Parkinsonism, the bradykinesia, along with the other rigidity, tremor that I was talking about. That's going to be that time zero mark. We know that there's some symptoms of Parkinson's disease that come up several years beforehand. RBD is referring to REM sleep behavior disorder, the acting out of dreams in sleep, kicking, throwing punches in sleep. And in some patients, constipation coming up even as early as 20 years before that. Though constipation is a very common symptom in the general population. So really hard to track down patients when that's occurring, but something we can put on our retrospective glasses and looking back say, oh, yep, that was there for our patients. Other things are going to be that change in smell, loss of smell, decreased smell, hyposmia coming up closer to the time of onset, and then other symptoms like depression coming up before that time of motor symptoms. After the start of motor symptoms, you can see that, and I'm colorblind, so there's this portion of the chart right here where it says dyskinesia fluctuations, and these start to come up during this 5 to 9 to 10 year mark is when it starts to come up. So it is something that occurs in the progression of Parkinson's disease as the disease progresses, and not necessarily inherent to the medications themselves, though it is a manifestation that occurs when you have too much medication in the system. And then later on is where you can start to get into some urinary symptoms, orthostatic hypotension, which is that dizziness with standing up, blood pressure dropping. And then as symptoms progress, you can get into freezing of gait, falls, postural instability later on. Any of these things happening outside of this order, we start talking about, is there something atypical or something different with the Parkinson's disease? Are we dealing with a Parkinson's plus or atypical Parkinson's? So we keep this type of chart in mind when talking with patients, both about when we expect symptoms to come up, how to treat them, and what that means for you. So let's talk a little bit about some treatments in Parkinson's disease. And before I go on talking about treatments, I just want to put a little plug in for research in Parkinson's disease. So in patients that are diagnosed early with Parkinson's disease prior to initiating medication treatments, there are some trials to look for patients who haven't started on dopaminergic treatments so that we can better do research on patients who haven't taken medicines. So we have better ideas of where the disease is going, as well as what lack of medication does to the patient. And it also makes for good patient trial participants. Here are a couple of websites. CU Movement is our movement disorders website at the university. And then there's also Parkinson.org as well as pdtrials.org that have national trials that are present. And then clinicaltrials.gov has international trials that you can review as well. Yes, please do. Thank you so much. That was such a good question. The question was, for those on Zoom, is are these trials just for patients who have not taken medications yet? And I want to apologize. The research that's being done is for patients in all stages of disease. So if you are on medications, you can participate in different clinical trials. We have trials for both patients who are on medications as well as not on medications. I just wanted to chime in and say, before we talk about starting medications, you might be eligible for clinical trials there. Yeah, that was a fantastic question. Thank you. Now, in terms of treatments, we have both the goals of wanting to treat symptoms that are present, and then ideally we would have treatments that would slow down disease progression. So we call that disease modifying treatment. In Parkinson's disease, we don't have a disease modifying treatment yet, but there's lots of research that are being done looking into different therapies that may help prevent or slow down the disease. So far, what we know is exercise is the only proven treatment that helps slow down disease progression. For those of you who are not exercising right now, I would encourage you to start, but don't jump into this optimal routine I'm talking about. Start slow and build up to it. Work your way up. Just do a little bit each day to get yourself exercising. The optimal routine is going to be cardiovascular aerobic activity 3 days a week, stretching 5 to 7 days a week, and strengthening 2 days a week. The cardiovascular activity, you want to try and target aerobic activity 50 minutes a day for those 3 days, or in general, 150 minutes over the course of a week. So 5 30-minute sessions would also get you there. That data is not just for Parkinson's patients, but for neurologic conditions in general, helping slow down the onset of Alzheimer's or dementia have been shown to respond to doing that kind of cardiovascular fitness. So exercise is very important. If you have arthritis issues or some difficulties there, swimming is a very good option to be able to take that tension off the joints and be able to mobilize yourself and get your heart rate up too. There's some resources for exercise classes, as we've heard about with our Parkinson's Association of the Rockies friends here in Sterling. They have an exercise class that I want to actually look in and see what they're doing for you. And then there's ParkinsonRockies.org as well as PWR for Life, which is the Parkinson's Wellness Recover, that also have some exercise options that you can look into. Take a sip here. Okay, so now I'm going to talk about some medications for the motor symptoms, and then towards the end I'll talk about some medications for non-motor symptoms. So medications, when we're using them, we're trying to talk about treating the motor symptoms of bradykinesia, that slowness of movement, that incoordination, the rigidity, the stiffness, difficulties with walking, freezing of gait, and tremor. Which is very commonly the rest tremor, but you can have some action tremor as well. So we'll start with levodopa, L-dopa. This is a medicine that is one of the more helpful medicines with those motor symptoms. It tends to have a short half-life, which means you have to take it more frequently so it stays in the system. And over time, the response to that medicine can wane because you just need more levodopa to make up for the loss of dopamine. So I have a picture here of the brain, and there's the substantia nigra. That's the dopamine releasing center that helps with controlling movement. And over time in Parkinson's disease, you have loss of those dopamine neurons from the substantia nigra, which leads to this low dopamine state. And that's what the levodopa is helpful for. Now, the medication we use very often, Sinemet, is carbidopa-levodopa. So there are two medicines inside of that one. The levodopa is the one that is the active ingredient that makes up for that loss of dopamine in the brain. The carbidopa helps the levodopa get into the brain. and keeps it from breaking down in your peripheral system, in the blood, basically. So it can help shuttle it to the brain. About 1% of the levodopa that is in medication actually gets to the brain, and actually less than 1% gets to the brain, and the carbidopa helps bring it up to about 1%. So it's still a very small amount that's getting to the brain. Initially, when levodopa was discovered, they had to hospitalize patients and put them on levodopa IV pumps. That was a really bad experience for patients because they would get very, very nauseous and start vomiting from just getting the levodopa all by itself, because all of that levodopa in the blood would contribute to those side effects. That's what the carbidopa helps with. Once that was developed, it was miraculous. We were able to have an oral treatment that we could send patients home with and have less of those side effects. So what are the side effects with levodopa? Early side effects, which tend to be temporary, but some patients can have this and not tolerate it as well, are going to be nausea, sleepiness, headache, some dizziness. Nausea is very common, and it's very common to talk to your doctors about starting with a small amount and working your way up on levodopa so that you can tolerate that initial side effect state. It tends to be a very well-tolerated medicine, but in some cases, some patients don't do too well with it. Some side effects to look out for are paranoia, hallucinations, losing touch with reality, believing things that aren't true. Those would be delusions. Those type of side effects are not so common with levodopa, but they can occur at really high doses. Of the Parkinson's medications, many of them can have some side effects of confusion and hallucinations. And I want to say levodopa is the least likely to cause that. But I brought it up here just to make sure you guys are aware of that. And that's from the brain getting too much dopamine. Dopamine doesn't only control movement, but it also controls behavior as well. And then I have a picture there with some of the other neurotransmitters, acetylcholine, GABA-glutamine. All of those things also influence how the body moves and how the brain acts. And the circuits tied in with dopamine are very interconnected. That's why a lot of these different medicines that are not levodopa also help out in some way too. More on levodopa. So it tends to be helpful early on in the disease. That's why patients tend to get started on it early. And different formulations are present, and you take different formulations depending on where you are in the stage of disease. Now, Parkinson's disease staging is really, really difficult and tough to follow through on, because just by taking medications, you can jump from one stage to another. Then when you are not on medications, you can fall back a stage. We don't like using the staging system. I don't, at least when talking to patients, because it's a good research tool, but it has no utility in predicting how far you're going to go. Okay. One thing we can look at is the response to levodopa and how symptoms are controlled. In the top chart there, I have that middle Goldilocks zone. You can see the levodopa when it gets taken, it builds up in the system and then wears off, and it does that multiple times a day, which is why we recommend taking it 3 times a day to start out. And when it dips too low, you get into off state, not enough medication to help with the Parkinson's symptoms. And then when it goes too high, you can get into extra movements, dyskinesia. Initially, the second chart is showing you how that dyskinesia and off threshold changes over time. So initially, you can be taking the medications, and then, does this work as a laser pointer too? Yeah, but Zoom can't see it, so I'll do this. We'll do pointer options, laser pointer. Okay, so you can see here, as you take a medication when you have milder earlier Parkinson's, that medication is going to give you this on time a lot more of the time. Over time, as the brain is making less dopamine and as the brain doesn't respond to that dopamine quite as well, or is more sensitive to the changes in dopamine, as the levels build up, you can get into dyskinesia a little bit more easily, or you can get into wearing off a little bit more easily, where it just has these peaks and these troughs in medication. You still have on time, you still have response to medicine here, but as the disease progresses, you can get into wearing off or the medication not kicking in as quickly as it did. Any questions about this chart here? Okay. And then one other thing is, as we get into this later stage of disease, this is where I start to talk to patients about protein and the levodopa. So you may read online or look into things that say, don't take your levodopa with protein. And that's true. Protein does get in the way of absorbing levodopa at a percentage rate. So if it's early on the disease and you're able to tolerate levodopa just by taking it with meals, I would prefer patients to be able to tolerate the medicine when starting out. But over time, I talk to patients about, oh, you know, it's potentially not working as well, not kicking in as well. Let's try avoiding protein, which is going to be things like meat, fish, eggs, yogurt, chicken, those kind of things. That if you take that at the same time as taking the levodopa, that's going to block its absorption, because levodopa itself is an amino acid. It's going to get absorbed by those same channels in the gut that protein is getting absorbed through. Yeah, so the waiting time is going to be avoiding 30 minutes before meals or 1 hour after meals. So taking medication, wait 30 minutes and then eat. Or if you eat, then wait an hour after you finish up eating and then take the medication. I don't like my patients to try and build their meals around their medications because they're already doing so much. But later on, when the wearing off or these difficulties with the medicine kicking in, it becomes bothersome, that's when we start talking about these things. I also forgot to mention, with those Parkinson's symptoms, that slowness of movement, the tremor, the trouble walking, you can have some amount of that that isn't bothersome. I imagine some patients early on before getting diagnosed had a time where they were having the symptoms where it's like, yeah, I have that symptom, but it's not bothering me so much. Or I didn't really notice that I had it. So some amount of bradykinesia, tremor, rigidity is not necessarily dangerous to you or bad for you. It's always a matter of talking to your doctor about, when am I bothered by these symptoms, so that we can talk about starting treatment or helping your quality of life. Because that's what's really important, helping your quality of life so you're doing the most that you want to do. And then levodopa is the medication that is associated with dyskinesia. And so when taking levodopa and those levels get to higher states in the body, once you have a later stage of disease, that's when dyskinesia occurs, because those neurons are more sensitive to the levodopa because of how they degenerate over time. Imagine you had a patient who went 8-9 years without taking medication levodopa at all, and you started them on levodopa therapy at year 8, year 9. They would develop the dyskinesias despite having waited those 8 years to start on the medicine, because they have just waited 9 years into their Parkinson's disease course. So there was this old state of thinking that dyskinesias could be prolonged or put off by waiting to take levodopa, but the pendulum has swung the other way, and there's been new data to suggest that that's not the case anymore. So in terms of medications for the levodopa itself, there are different formulations of levodopa that are present. There's the immediate release carbidopa levodopa. This is usually the Sinemet that gets started initially. There are immediate release carbidopa levodopa formulation called Divi. That's something where you can quarter the tablets. So if you're someone that is really sensitive or needs really small changes in the medication, that could be a lot easier to break down into quarter pills, so you could try and increase the dose incrementally. There's Inbrija, which is inhaled levodopa. So it helps get levodopa into the system in about 10 to 15 minutes. But this is more of a rescue type therapy for wearing off or medicines taking a while to kick in. Another alternative is chewing immediate release carbidopa levodopa and taking it with some carbonated beverages can help it kick in quicker as well. Then next there's Cinemet controlled release, CR, and sometimes this gets labeled as extended release. And this is a very frustrating thing for some movement disorder specialists and for patients too, because when we start talking about other longer acting therapies, insurances will want you to try an extended release earlier. And Cinemet controlled release is not exactly an extended release, but a different formulation of the pill for the immediate release Cinemet to slowly leak out of the pill capsule, basically. More extended release formulations that have come out that are a bit newer, things like Rytary and Crexont, which are combinations of immediate release and extended release beads that slowly are released in the small intestine so that they have a more sustained peak of action before they wear off. And that's what the chart is showing over there, where this initial curve is the immediate release Cinemet kind of peaking out and wearing off over time. And each of these curves are 1, 2, or 3 of these Rytary pills and how much the plasma level maintains before it wears off. Other treatment options with levodopa are going to be things like the Duopa pump, which is a pump that is surgically inserted to help bypass the stomach and deliver levodopa gel to the small intestine. And then a new pump has come out, subcutaneous levodopa, Vyalev, which is a type of, think of it like an insulin pump for levodopa. So it's getting into the system continuously.
There was my discussion with my doctor. Sorry.
You're okay.
The something was not well accepted by the medical field. Sorry, being boss of it, or it's called something about it wasn't set well with her.
Yeah, one of the things that came up with earlier trials and clinical experience with Rytary is it really helping patients have more on time or taking medication less frequently? And so initially in those trials, they wanted to see whether patients were able to decrease the frequency of how often they were taking it, but they didn't let patients adjust the dosing in the trials. And so patients could have some side effects of dyskinesia and things like that that were bothersome, but they weren't allowed to change the dosing frequency with patients. And they made recommendations to start the medicine at the clinical trial parameters where patients may not all need those clinical trial parameters, which were they forced patients, however often they were taking medicines, to everybody take it 3 times a day. And we've learned in clinical practice that with Rytary, patients may still have to take it 4 or 5 times a day. And that might be what your doctor was talking about there with Rytary, patients still having to take it somewhat frequently. But it is still less frequent than some of my patients who are taking medication up to 7, 8, 9 times a day as well. Here's some pictures of some of the different therapies. This is that Ambrosia Rescue inhaled levodopa. This is Divi with its quarter tablets. This is a Duopa pump here. This is the Vyalev subcutaneous pump and kind of these little carrying cases the patients have with their pumps. So that was levodopa. Does anybody else have any other questions about levodopa before I talk? Yes. Yeah, so typically you can expect it to kick in within about 30 to 40 minutes is how long it takes to actually start getting absorbed. Some patients have told me that they feel it kick in as early as 20, 25 minutes after taking it. Over time, as non-motor symptoms progress, things like constipation, dopamine is the neurotransmitter of movement, and our gut also relies on dopamine to move, so that gut can slow down over time. And so sometimes it doesn't leave the stomach immediately in that 30 minutes to get absorbed. And so it can take longer if you're dealing with a lot of constipation or GI difficulties as well. So that's another consideration for some of these advanced therapies beyond the immediate release. Next treatment I want to talk about, and I'm kind of going in order of how well they help treat the motor symptoms. So next up are dopamine agonists. These do really well and almost just as well as levodopa for treating those motor symptoms of bradykinesia, rigidity, tremor, walking difficulties. Dopamine agonists, because of their mechanism on how they work on their receptor, don't cause dyskinesia, and when you take them, you don't have dyskinesia while taking them. The trade-off with these class of medications are their increased side effect profile, more likelihood to having nausea, tiredness, sleepiness, to the point of sleep attacks and suddenly falling asleep can occur, some leg swelling, and more increased risks of cognitive difficulties with confusion, hallucinations, delusions. And the one thing I worry about and screen for is impulse control issues. So that's going to be things like gambling, excessive spending, excessive hobbyism, spending too much on mobile games like Candy Crush, things like that. And then one of, like I was talking about before, an older thinking being to start dopamine agonists earlier on to help delay dyskinesias, but we've shown that just progressive Parkinson's disease and reaching year 7, 8, 9, if you were going to have dyskinesias, those dyskinesias were already going to be present. But these can be really good medications to the point where patients don't have to take it as frequently. And they have other formulations for this as well, such as patches, reticotine patch. You can bypass the gut with that option. And then there's also a subcutaneous pump for apomorphine, which is another dopamine agonist. That one only got FDA approval to be used during daytime hours, whereas the subcutaneous levodopa got approval to be used 24 hours. So it can continue to be worn overnight, whereas this one can only be used during the daytime. And I just put this back up here to talk about when dyskinesias are expected to pop up.
So a minute ago, you
Yes.
talking about in fact 7, 8, 9, I presume those 3 years.
Yes. Yeah.
So when do you start counting?
Yes, that's a good question. When do you start counting to progression of getting to dyskinesias? I had a patient that I talked to about this just the other day, and she said, you know, I've been diagnosed for 3 years, and this is really early for me to be getting dyskinesias. But I didn't write in my note that I was actually counting from this time 0. So from when she first developed symptoms of tremor, that first symptom of when that motor symptom started. So usually in Parkinson's disease, it's a unilateral one-side onset of tremor, resting tremor, or stiffness, rigidity in coordination. And that's where I start the timer. Now, some other medications. You have medications that I classify as dopamine extenders, though MAO-B inhibitors don't technically work to extend dopamine. MAO-B inhibitors just increase the amount of dopamine that the body's already making through a mechanism of preventing its breakdown. 2 options there are selegiline and rasagiline. And the real dopamine extender are COMT inhibitors, things like entacapone, opicapone, or Stalevo, which combines carbidopa, levodopa with entacapone. They work by helping prevent the breakdown of the levodopa even further in the central nervous system. And they only work if the patient is also taking levodopa. So with MAO-B inhibitors, that can be taken by itself without any carbidopa, levodopa. It tends to be kind of third in that order of how well the bradykinesia and rigidity can respond compared to levodopa and dopamine agonists. But it tends to be better tolerated with a lower side effect profile. It's also a little bit stimulating. So in some patients that talk about having a lot of fatigue or decreased energy, some of those MAO-B inhibitors can be helpful to maybe get a little perk in energy. Side effects with those can also be some nausea, headache, insomnia, just because it's stimulating, it can keep you up. And then some blood pressure changes, more commonly being kind of that increased blood pressure side of things. COMT inhibitors, those help the levodopa that you're taking last a little bit longer. What I quote patients to expect is 30 minutes more on time per dose. So you take a COMT inhibitor with each dose of levodopa, so you're taking one more pill just as frequently, or Stalevo, which has entacapone built into it. Some patients can notice anecdotally like an extra hour to an hour and a half of on time, but what was done in the studies and shown in the studies was 30 minutes more of on time per dose. Side effects with that, if you're making the levodopa work better, you're gonna get more of those levodopa related side effects. Things like dyskinesia and nausea are very commonly there. The way they make the pills, one of the the wrapper, if you will, of the pill basically causes the urine to change colors to this orangish color. Doesn't mean you're bleeding in the urine or anything. That's just how you're processing the pill. So that's something I tell patients to look out for when getting started on a COMT inhibitor. Now, other symptoms are going to be dyskinesias. Let me see if I can go back to my other options. Okay, so there's Michael J. Fox in an interview, just to kind of show what some of those dyskinesias look like there. He's on medications, talking with Dr. Gupta, and you can see he's having some dyskinesias. He's not currently bothered by the dyskinesias. He's able to partake in the interview and do his daily thing. In terms of when we talk about medications for dyskinesia, dyskinesia itself is not inherently dangerous to the patient and is reversible. You just have to lower the amount of levodopa or take the levodopa with protein, block its absorption a little bit, and you can have less dyskinesias. But we talk about treating dyskinesias when it's bothersome to the patient, to the point that they're knocking things over or embarrassed by having it while out in public, or if they're falling over, not safe walking with having the dyskinesias. I've had patients who looked very dyskinetic and concerning to me, but they themselves didn't even notice that they were having dyskinesias. It's very common that dyskinesias are noticed by the care partners and family before the patients even realize that they're having dyskinesia. So I don't want patients to start chasing down or worrying about dyskinesias unless it's impairing their day-to-day function. The treatments for dyskinesia, like I talked about, taking protein is a non-medication option to help slow down how much of that's getting absorbed, because typically dyskinesias come out as the medication is peaking. If you remember that immediate release Cinemet curve where it really spikes up in comparison to some of the other medications, it's usually when taking the medicine within that 30, 40 minutes of it kicking in that dyskinesias come up. But there are some patients that outside of when it peaks out, some patients where they start taking the medicine and as it kicks in or as it wears off and that level is dropping really quickly, that they can get dyskinesias too. So those are some things to talk about with your doctor if you're experiencing that, to help distinguish between it. It's also very helpful to keep a pattern of that in like a journal of when do you notice your dyskinesia? Is it several hours after taking the medicine? Is it a couple of minutes before I'm due for my next dose? Is it 30 minutes after I take my dose? That can help us know what kind of dyskinesia the patient's experiencing. Medication treatment options. Amantadine is the only one that we have that treats dyskinesias themselves. Amantadine comes in both immediate release and extended release, Symmetril and Gocovri. And amantadine is associated with side effects of hallucinations and confusion because it has an anticholinergic effect. And then it can also cause some ankle swelling. And I put a picture here of the skin changes, livedo reticularis, that can occur. The skin changes isn't dangerous to the patient. It's not causing blood clots or things like that, but it is just a skin change that cosmetically can be difficult for patients, or they may not know what's happening when it occurs. And then tremor. So tremor tends to be difficult to treat in Parkinson's disease. Medications that such as levodopa need much higher doses to actually get the tremor under control. And like I said earlier, it's really important to always keep in mind what is bothering you and what's debilitating to you. So sometimes having a little bit of rest tremor can take a lot of levodopa or dopamine agonists to actually get that symptom under control. And if it's not bothersome or debilitating, we don't necessarily need to chase it down. Some patients can have very debilitating tremor. Some medications that work really well for tremor are anticholinergics. You may have heard of things like triacylphenyl, artane, cogentin. And these medicines first were used in the drug-induced Parkinson's space. So there are medications such as some antidepressants, sleep medications, medicines for bipolar, schizophrenia, really bad depression that block dopamine. Like I mentioned, dopamine's not just movement, but also how one is thinking is a response of dopamine. So blocking the dopamine receptors in those other conditions had this unintended side effect of causing Parkinsonism in some patients. And so they used anticholinergics to help treat those symptoms. And we found that the tremor actually responds quite well to anticholinergic therapy. Now, anticholinergics work really well in patients when they're younger, and that's only due to the tolerance of the medication. It's very likely to cause side effects of confusion and hallucinations. Other side effects, and you can age into these side effects as well. So if a patient is on anticholinergics from a younger age and then they grow into 65, 70, and they start to have confusion and hallucinations, this is actually something that is really easily treatable. We talk about coming off of those medicines, discontinuing them. So then patients aren't experiencing as many confusion, hallucinations, and it may not be psychosis from Parkinson's, but just side effect of medication that's causing symptom. So important to keep in mind that as we age, we can get side effects to medicine too. Other ones that anticholinergics cause are going to be urinating difficulties, bowel difficulties, nausea, dizziness, dry mouth, blurry vision. Amantadine is a medicine that, like I mentioned before, for dyskinesia, has a little bit of anticholinergic effect. So it has some of those same side effects, but a little bit less than anticholinergics, which means it can also be used for tremor as well. So your doctors may talk to you about starting amantadine, and you may not be having dyskinesias, and it might be to help out with tremor too. And I'm going to go back for a sec. To treat tremor with levodopa, at least when I'm starting a patient on levodopa and they have really bad tremor that they're wanting to try and get under control, really reaching that 200 to 300 milligrams of levodopa, so 3 of those 25 100s per individual dose, is what you need to get to or be able to tolerate to actually start to see tremor improve. Now, ways we can treat tremor that are not medications are take away medications that are worsening tremor. So like I mentioned, dopamine blocking therapies can cause Parkinsonism and also can cause a lot of tremor. Some common ones that have been used are Abilify, haloperidol, risperidol, olanzapine. If any of those sound familiar, those can potentially be making tremor worse. Valproic acid and lithium have also been used for psychiatric conditions, and they cause some very severe tremors. And then some non-neurologic or psychiatric medications should also be considered as provoking tremors. Things like asthma medications, albuterol can exacerbate tremors, theophylline. Heart medications like amiodarone or procainamide, and some other heart medications too. Nausea meds like Reglan and Compazine, and then some HIV medications and some cancer medications. So definitely review some of those medications with your doctors if tremors are really bothersome. Antidepressants, I tend to be hesitant to take patients off of their antidepressants if depression's really bad, because I don't want patients to hurt themselves or be at risk of hurting themselves or others. So it's always important to weigh risk benefits of changing medications for what they're treating versus what you're wanting to improve. And then sometimes we use essential tremor treatments in Parkinson's patients as well. So like I mentioned, that rest tremor when you're not doing anything is the common kind of tremor that is part of the diagnostic criteria in Parkinson's disease. But many patients with Parkinson's can have tremor when they're using their upper extremities, an action tremor, when they're trying to use their phone, hold their phone, drink a cup of coffee, do all of these kind of actions, feed themselves. And that action tremor tends to respond better to essential tremor treatments. Common essential tremor treatments are going to be blood pressure medicine like propranolol, a beta blocker, kind of works in the opposite sense to how albuterol works as a beta agonist. That way it also can make asthma worse. So if you have asthma or COPD, that might be a medicine you want to be careful of. Other treatment options for essential tremor that work quite well for the action tremor are primidone. Tends to be a medicine that also is associated with a little bit of trouble with cognition and can cause some tiredness and sleepiness. So tends to be one I'm a little bit hesitant to use in Parkinson's patients, but I am willing to use it if that tremor is really bad. Other options that don't do as well as propranolol and primidone, but do work well for essential tremor, gabapentin and topiramate can also work. And then for patients who have a prior diagnosis of essential tremor, because some patients develop tremor first and get diagnosed with essential tremor before the Parkinson's disease, there is something called the Calitrio or TAPS therapy, which basically can be used on one side of the body is what Medicare is covering for it, but it uses little TENS units, shock-like stimulation, just in a wristwatch type format that takes your tremor and sends a little stimulus back towards the center of the brain that is responsible for the tremor to help disrupt that tremor. And it doesn't make tremor go away completely, but it brings tremor down to the point that you're able to function and do things that you want to do better. Show of hands, how many of you have drawn these kind of spirals for your doctors? Curious. Okay. If you're having a lot of tremor, the tremor that I showed you up here, the one on the left, is a typical tremor spiral of a patient who has essential tremor. And that's before and after some treatment. So any questions about motor treatments? And then, of course, as I mentioned before, one of the motor treatments I did not talk about was deep brain stimulation. But that can be an entire lecture in and of itself, and several different lectures. But that's also there too. Deep brain stimulation is only used for the motor symptoms. So anything we're going to be talking about now, the non-motor symptoms, these do not respond or change with deep brain stimulation, and they have their own treatments. Okay. So for non-motor symptoms, I'll go through some of those ones I talked about earlier. Trouble thinking or dementia or trouble with memory. Number one treatment, improving sleep. Sleep is going to be really important to being able to think cognitively during the day. And then diagnosing why someone has difficulties with sleep. Something really common in Parkinson's disease, despite not having the typical body habitus, is sleep apnea. You can get both obstructive sleep apnea, tongue falling back, blocking airway, as well as central sleep apnea, brain not telling me to breathe as much at night. That occurs very commonly in Parkinson's patients, despite not being obese or having very large neck circumferences. So if you are snoring at night, or if you are pausing your breathing in your sleep, or having little pauses that you get choked up, that can wake you up and disrupt your sleep. It's very important to treat sleep apnea if it's present, because it also provides a risk for developing high blood pressure, strokes, cardiovascular disease, heart attacks. So very important to get that under control, and also can improve your trouble thinking if it's present. Sleep apnea can also worsen some sleep movements. So not all of your acting out dreams in sleep may be REM sleep behavior disorder, but some of that can be sleep apnea, because if you pause your breathing in sleep, you're kind of suffocating, and then you're going to try and fight to make yourself start breathing again too. Now, medications that can be used for trouble thinking, we borrow from other diseases. So medicines that were developed in Alzheimer's dementia. Medicines like donepezil or rivastigmine have been shown to be helpful in Parkinson's patients or patients with dementia with Lewy bodies. And these work by helping to increase a substance known as acetylcholine around the brain. And that can help with maintaining more attention or kind of being awake enough or kind of processing enough, alert enough to be able to get that information in or help the brain go retrieve the information that it's having difficulty with retrieving. That's a very common pattern to the trouble thinking in Parkinson's patients, where it's not that they've lost the memories, but it's they don't have that attention or focus to be able to go bring that memory forward. So some strategies to help with that are cognitive rehabilitation. And the experts in this are actually speech therapists. Speech therapists who you may have talked to about for quiet voice or hypophonia or trouble swallowing. They also do a very good job of talking to patients about thinking and memory and strategies to help them with that. Now, if you do go down the medication route with things like donepezil or rivastigmine, side effects to look out for are nausea, diarrhea, stomach cramping comes up a lot with those. Cardiac effects with like slowing down of heart rate. So if you have a slow heart rate or a heart block of some kind, not a good medicine for you. And then weight loss can come up with these, as well as some more vivid dreams. One other thing. With the donepezil and rivastigmine, caveat is these can be used for one motor symptom, and that's going to be freezing of gait. So that's going to be where patient is walking and they have this disconnect between brain and leg movement, and the foot gets stuck. They can't get that next step going forward. So they need to use some strategies like looking at a pen on the floor and stepping over that, or marching in place before they can start moving again, or tapping their leg, or thinking of a phrase like kick the can to make themselves get that leg moving. These type of medicines can help with that particular kind of gait difficulty called freezing of gait that sometimes doesn't respond as well to levodopa. Now, hallucinations and delusions. So similarly, it's a matter of trouble thinking. The brain isn't processing reality around it quite as well. You can potentially see a shadow or see a coat hanger on the wall and then think, oh, is there a person there? And you look at it, you're like, no, that's not a person, that's just a coat hanger. But with the trouble thinking in Parkinson's disease, it can be that you're having that difficulty retrieving that memory of, oh, coat hangers go on the door, so I'm seeing a person that's there when they're not actually there. So similarly, medicines that help you with retrieving those memories or paying more attention to things, like donepezil and rivastigmine, even though those are used for memory, can also help with hallucinations and delusions. In the event those kind of things don't work, there are other medications that also work for hallucinations, delusions, paranoia. What we like to use is Seroquel, which blocks dopamine. And you'll remember me mention earlier that blocking dopamine can make Parkinson's symptoms worse. Well, Seroquel is one that blocks the motor dopamine receptors a lot less than any of the others. It's the least likely to block dopamine receptors until you get to doses above 200 milligrams. So doses less than 200 milligrams of Seroquel can actually help with improving hallucinations. Then we have non-dopamine blocking antipsychotics. One that was developed specifically for Parkinson's patients with dementia was pimavanserin or Nuplazid. That's a medicine that can be used specifically for the indication Parkinson's disease, dementia, and having hallucinations and delusions. And then there's some other medications, one known as clozapine. This one has a really stringent requirement of getting weekly blood draws to be able to take. So it's not very commonly used, but it does have quite a bit of anticholinergic effect to be able to help with tremor, and it does not block dopamine, so it does not make Parkinson's symptoms worse. The only difficulty with it is that weekly blood draw component. There used to be a program here that the FDA had called the REMS program, where the blood work would get submitted to this central monitoring service that your doctor would look over and make sure that you weren't developing this dropping of a blood cell count that is monitored. The FDA actually got rid of the need to monitor that program, but doctors are still going to be doing weekly blood draws to monitor for that side effect that occurs. The US in like when the program was present was the only country that was doing that monitoring program. So clozapine has been used in other countries in Europe and did not have a monitoring program. So the fact that that went away doesn't mean that we're doing things any differently. So another thing about hallucinations and delusions, reducing medications that can cause the trouble thinking. So here is a very large list of medications, but in terms of what these are doing, they're blocking that acetylcholine that can cause more difficulties with hallucinations. So avoiding the strong anticholinergics can help with having less of those. There's something called the Beers criteria, BEERS, that gets updated every couple of years to identify what are very likely causes of anticholinergic blockade. So some common antidepressants, antiemetics, antihistamines, first generation antihistamines, so things like Benadryl, meclizine, promethazine, those kind of things. Antimuscarinics, so those are used commonly in urinary symptoms, like trospium and oxybutynin. Some of the Parkinson's tremor agents I talked to you about, benztropine and triacylphenidil, and then some antipsychotics as well. Antispasmodics, so some medicines that help with the GI system. And then skeletal muscle relaxants, muscle relaxers like cyclobenzaprine. So talk to your doctors if you are on some of those medications and experiencing any hallucinations and delusions, because you could potentially decrease some other non-Parkinson's medicines that are making psychosis worse. Urinary difficulties are a common non-motor symptom in Parkinson's disease. If you are having urinary difficulties, having a urologist expert on board is very important, because as patients age, urinary difficulties are very common amongst the general population. So making sure you don't have a common problem contributing to urinary difficulties outside of the Parkinson's disease. But urinary symptoms can get worse in Parkinson's patients and be exacerbated by things like sleep apnea. So treating sleep apnea can make those symptoms better. There's a class of medicines that does not contribute a lot to difficulty with thinking, beta-3 agonists, Myrbetriq and Gemtesa are some of those. And they treat overactive bladder symptoms, so that sudden urge of I gotta go to the bathroom. Other medicines for different type of bladder symptoms can sometimes contribute to trouble thinking, but some of them don't cross the blood-brain barrier as much. So talking with your doctors about that is very helpful. Another thing that has come up, urinary difficulties does respond to levodopa too. And so if you are wearing off overnight and having some difficulty with urination, that could be a non-motor symptom that responds to levodopa. Constipation is very common in Parkinson's patients, being one of those prodromal symptoms that comes up to 10, 20 years before the disease and gets worse over time. Things that you want to do, hydrate, hydrate, hydrate. Drink lots of water, because that can help with hydrating those bowels. Soluble fiber over things like Metamucil, which is a non-soluble fiber. Soluble fibers will dissolve in water, so things like Benefiber. They only work well if you stay hydrated to help with forming more solid stools that can help push the stools forward. Exercise, getting moving, staying active, that can help move those bowels too. So at some point, some patients need to sometimes add in things like a daily stool softener. Sorry for my misspelling there. Docusate is an over-the-counter option for that. Magnesium can help with stimulating the bowels. And then what I really like to use in patients is Miralax. It's also a powder supplement that can be mixed in with water, and then you take that to help stimulate having a bowel movement. With Miralax, you can increase or decrease the amount of powder you use to try and get to having 1 bowel movement a day is where you want to be. And if you're not having one, then you can kind of increase it to find what you need to get to having a bowel movement a day. Sometimes you need multiple of these interventions all together. And then sometimes you need a GI referral to help with getting those under control. So those are things about constipation. Insomnia, REM sleep behavior disorder. Insomnia, trouble falling asleep or trouble staying asleep is very common in the general population as well as Parkinson's patients. Sleep hygiene is really important to help give yourself the best chance at falling asleep. So avoiding blue light 1 hour before bed. What's blue light? Blue light is that activating signal that suppresses the brain's melatonin centers from producing melatonin. And Parkinson's patients are already fighting an uphill battle because the brain in Parkinson's patients does not make as much melatonin. And so you want to give the best chance to the brain to make its natural melatonin that it's going to. So blue lights are going to be found in television screens, phone screens, tablets, computers, all of those kind of things. So you want to avoid that an hour before bed so that the brain can start getting that signal of producing melatonin. And then melatonin can be helpful to help with increasing the brain's melatonin, supplementing the brain's melatonin that it's not making. Melatonin is also very helpful for the treatment of REM sleep behavior disorder. So those acting out dreams, kicking or throwing punches in sleep, hitting our bed partners, falling out of bed, falling into furniture, things like that. We want to avoid having any of that at all. So if you are having REM sleep behavior disorder, trying to keep furniture away from the sides of the bed. So should you fall out of the bed, you don't fall into that dresser mirror. Or if you have a bed where it's really high up, you want to minimize that distance you're falling to the floor. So maybe getting a new bed that is closer to the floor, so it's not as far to go. Sleep apnea can definitely worsen sleep symptoms, and I've talked about that a lot. And then as a kind of last ditch or kind of a later treatment consideration, clonazepam can be used for REM sleep behavior disorder. The clonazepam itself is a medication that can cloud thinking a little bit, but we can use very, very small doses and help treat REM sleep behavior disorder. Clonazepam can also exacerbate breathing difficulties in sleep. So if someone does have sleep apnea, we want to be careful with those. And then remembering in part of that sleep hygiene, there's only 2 reasons to have the bedroom present. It's to go to sleep there and to have intimate time there. So taking television screens out of the bedroom, it's not a place to be journaling. Trying to avoid reading that heavy-hitting novel where you're just keeping on turning the page. Doing those things in the bedroom will make the brain associate the bedroom for that kind of space. So it'll worsen insomnia too. Okay. And then there's a lot of non-motor symptoms, and I didn't talk about all of them in the presentation, but be happy to talk about them as well if there were any questions that came up. Anxiety, depression, that's an entire specialty of itself in psychiatry to talk about all the different treatment options that exist there. Apathy is one of those non-motor symptoms that I talked about earlier that doesn't respond as well to medications, that difficulty finding the joy in doing the things you want to do. And one of the things that helps out the most with that is scheduling regularly scheduled activities. So you guys all scheduled to come out here, and that's the exact kind of thing you need to be doing to help with treating that apathy. Because once you actually get to doing those things that you want to do, can you start to build in that routine and enjoyment? And that's something that patients have responded well to. Sometimes that apathy is masking depression, and so it can respond to treatment if depression is also present. So sometimes antidepressants are helpful in those cases. And then talk therapy, seeing a psychologist or behavioral health specialist, social worker, somebody to talk through some of the difficulties that you're going through can be helpful with the apathy as well. Sexual dysfunction is common in Parkinson's disease as well. Fatigue, orthostatic hypotension, that's the blood pressure dropping, getting dizzy, lightheaded when you stand up. Orthostatic hypotension, a couple of the medicines that help treat the motor symptoms can make the orthostatic hypotension worse. So trying different medications can be helpful there, as well as there's a whole set of medicines to help with orthostatic hypotension. Staying hydrated is one of the best things that you can do if the blood pressure is dropping. So getting 64 ounces of water a day and decreasing the amount of caffeine can also be helpful. Caffeine is a diuretic and can dehydrate you as well. So for every cup of coffee that you're having, a cup of Coke or caffeine, you want 2 cups of water to make up for what you're losing in that caffeine. So I've got my water here that I'm going to drink after I finish my coffee. Other things, salt treatment can be helpful for orthostatic hypotension. Increasing that salt in your diet can help with getting water to basically third space into the blood to help fill up the tank a little bit more. But you have to stay hydrated for the salt to actually retain the fluid as well. Definitely talk to your doctor if you've got cardiac conditions, high blood pressure, things like that, before just going and adding a whole bunch of salt to your diet as well. And then drooling is very, oh yeah, yes. Try to cut off your water intake at about 2 to 3 hours before bedtime. So target that early in the morning because having that fluid 2 to 3 hours before bed will make you more likely to wake up overnight. But if you are someone that notices that you're getting dizzy, lightheaded when you do go to the bathroom overnight, if you're already going overnight, I would definitely continue to maintain hydration. What naturally occurs physiologically is our blood pressure drops when we're in a resting state, opposite of fight or flight response. And so blood pressures are naturally a little bit lower overnight. So if you're already having orthostatic hypotension with the blood pressure dropping, when you get up to go to the bathroom overnight, you're more likely to pass out and fall. And we definitely don't want that happening overnight. So if you are experiencing it, you want to have less of that going to the bathroom overnight, 2 to 3 hours. But if you're feeling really dizzy overnight, then you may want to stay a little hydrated. Good question. In terms of drooling is pretty common. Everything is slowing down in Parkinson's disease, including how quickly we're swallowing saliva. And so if drooling is problematic, you can use certain kind of eye drops is what I prescribe because they don't have specialized drops for drooling. But these special eye drops, atropine, can be put on the tongue to help decrease the amount of saliva you're producing. Then Botox injections into the glands that secrete saliva can also be done to help with decreasing the amount of drooling someone is experiencing. And then trouble swallowing is another non-motor symptom that not all patients experience, but can come up. And there are some very common causes of trouble swallowing in just the aging population too. So having speech therapy or swallow assessments to make sure you don't have some abnormal anatomy that's contributing to trouble swallowing is important. But then also, if the earliest signs of trouble swallowing is actually going to be things like coughing on pills, liquids, or solids. So you may not overtly need the Heimlich after you eat something, but if you do notice you're coughing on some of those simple to swallow things, then that's an early sign of trouble swallowing, and that's when we need to intervene. We don't want to wait until we end up choking on something and getting into the hospital from a pneumonia to then start to address swallowing difficulties. Okay. Yes. Mm. Mm-hmm. I don't have a treatment for it. In creating this presentation, I was trying to look for a treatment that would potentially help that runny nose symptom, and I did not find anything that had any evidence behind it. And I haven't worked with a patient yet that has talked to me about that as a concern. So something that I'll have to do some more reading on and see what works. But that was all I had for the presentation. So it's now 11:30, so about 30 minutes left. So we can definitely just chat and talk with any questions you guys have. But thank you for having me. I'm going to take a quick sip of water. Okay. And I saw her hand up, and we'll just kind of work around the room. Go ahead. Okay.
I also take surgery.
Okay.
What is the surgery do?
Yeah. So the question is, what does selegiline do? And the patient is already taking both immediate release and CR Cinemet. And so what selegiline does is it's a MAO inhibitor. And if I just do this, I can pull up one of these pictures that can be helpful. Yeah, so it's a MAOB inhibitor, and it works inside of the brain to help decrease the amount of, it helps decrease the breakdown of the dopamine and helps keep the dopamine around. So the dopamine that the brain is already producing, it helps keep it from being broken down. But it also works on some other neurotransmitters too. So not just dopamine, but also some serotonin and some norepinephrine are also affected by MAOB. Yeah. And it's also a irreversible inhibitor. So once you take a dose of the MAOB, it does its action for about 7 to 14 days. So stopping that medicine takes about a very long time to kind of wash out. So it has a very slow effect that's noticeable, and then it wears off very slowly. It's also one of the ones that you should also keep in mind and let anesthesiologists know about for surgeries and things like that if you're on selegiline or rasagiline, the MAOB inhibitors, because it can interact with some anesthesia. So always being sure to keep your anesthesiologists aware of your medicines. That also reminds me, there's the Parkinson's, the National Parkinson's Association has this hospital tips and tricks kit. So like my Parkinson's medication regimen and my hospital action plan for what to do when you go to the hospital, and for your doctors to know when you're taking certain medications. That can also be helpful when you go into the hospital for various procedures and things. Go ahead.
I have a couple questions.
Mhm.
Are involuntary movements of the feet during the day and when trying to go to sleep at night, not just at night, talking about restless leg
Mhm.
necessarily,
Yeah.
is that dyskinesia? Is that tremors? What is it?
Yeah. And then what are your other questions? Just so I can have them down.
Doctor says, can you feel like your carbon levodopa has worn off? And he says, no, I can't tell if I, that it helps me, but it keeps taking it.
Okay. So the first is, what are these involuntary movements in the feet that occur? And that's a really good question, because I did not talk about what you're talking about there. So there is another movement that I didn't mention in the presentation that comes up in Parkinson's patients called dystonia. Dystonia is different from dyskinesia. Dyskinesia are random, unpredictable, involuntary movements that flow from joint to joint. And that's levodopa-induced dyskinesias for Parkinson's patients. And then there is dystonia, which is sustained involuntary contraction of a muscle. Very typically will be toe curling that can occur in Parkinson's patients. It's the same toe curling that occurs recurrently, or the foot turning inwards as well. So some foot turning dystonia. So when it curls or turns in the same way every time, that is dystonia. Now, dystonia can be a form of dyskinesia. It can be an extra movement that comes up from medication, but also more commonly, it can be a wearing off symptom. So when the medication is dipping, or when you're getting to the next dose, or it's nighttime and your daytime medicines are wearing off, that toe curling dystonia can come up, or that foot inversion can come up. And that can be a sign that the levodopa is wearing off over time. In terms of treatment of that, it's either try and get that levodopa better balanced throughout the day and night, or Botox injections into those muscles that are pulling or causing that curling for dystonia to weaken those pulling muscles so that the other muscles that help keep it straight have a chance to work out. So those are two treatment options that I didn't talk about. And then when I had mentioned earlier, dyskinesia can occur as the medicines are kicking in or as the medicines are wearing off. Sometimes that kicking in of the medicines can be associated with dystonia, and it can be a painful wearing on dystonia or kicking in dystonia, and that can actually be a dyskinesia. So that's why it's important to kind of diary out that association of when you notice different movements, what is happening, and the timing of the medication. Because we can't make the diagnosis of what that is unless we know the full story of what's going on. Does that answer that question? Yeah, okay. And then the other question is if the patient is going to the doctor on levodopa therapy and is being asked the question, do you notice it's wearing off? And the patient is responding, you don't know whether you even get a response to the medicine, can't tell a difference with it. And what was the question after that? So that was the situation. The question is?
Keep taking the medicine and.
Okay, yeah, should you keep taking the medicine or what to do next? So in patients who are not responding to levodopa, there's a couple of things that can be going on. One is maybe a patient had responded to levodopa previously, and the brain is making less dopamine over time. And say this is the threshold to where you start to get symptom benefit. So earlier on, you got symptom benefit from the levodopa. But now as the brain has made less dopamine, you're living down here. And you never get to symptom benefit. So potentially you have to increase the dose to get to symptom benefit. The other option is you try to fully increase that dose to really tell, does the patient respond to levodopa? The amount of immediate release Sinemet to try before you say the patient does not respond to levodopa is at least 900 milligrams in a day. So 3 tablets 3 times a day at least, to then be able to say this patient does not respond to levodopa. If the patient does not respond to levodopa, then you need to talk to the doctor about a diagnosis other than Parkinson's disease or an atypical Parkinson's disease. But if you haven't tried that much, then you could just be living down here, not getting benefit of medication so you don't notice wearing off. So it doesn't mean you have an atypical Parkinson's if you're not responding to medicine. You may just need some more.
So is there a limit to what you can take of it? I mean, can you go over that 900?
Yeah, I have patients who are on up to 2,800 milligrams of levodopa in a day. They need it. Sounds like a lot, yes, but that's what they need because their brain's not making enough dopamine. So that's the situation, that if the brain's not making enough dopamine, you treat to make the difference, treat to help bring up the intrinsic amount of dopamine so you're making that difference. Remember, only 1% of that carbidopa, levodopa, the levodopa is getting into the brain as well. So yeah, but that I heard you mentioned that's not very much, but it's enough to help patients feel better. So it doesn't have to be a ton, it just has to be enough to help you do what you need to do. There was a medicine I did not necessarily talk about, the carbidopa itself. They actually make carbidopa by itself. So if you are having side effects to the levodopa, you can take additional carbidopa to help prevent that side effect and better tolerate the levodopa. And then some of the options that basically don't peak out as much and build up more steadily and wear off more steadily, the more extended release options. They have sometimes some variable absorption that are not associated with as many of the side effects from peaking out on the medicine. Okay. And I think I saw a hand over here earlier. No? Okay. Go ahead.
How about the muscle pain? Is that, in my class, we do like the shoulder to the neck, it's a lot of pain. So
Yeah.
how they can take, like, I know they take medicine before the class,
Mhm.
during the class as well. What happened with this kind of pain, like every day, every single,
Mhm.
time?
Yeah. And so the question is neck and shoulder pain before exercise and what treatment options there are for that. So it comes down to what is the diagnosis? What is going on when that occurs? When I hear that story of neck and shoulder pain, that is kind of proximal axial pain. So we have muscles here that can get rigid and tight, and that can be the Parkinson's itself. But then there's another kind of pain, something called coat hanger pain syndrome, because that's the part where you hang a coat. It is due to orthostatic hypotension. So when the blood pressure is dropping and the blood flow is not going to those muscles as well, it can cause that pain too. So that can actually be a subtle sign of blood pressure dropping that is occurring. So it's important to have the patients talk with their doctors, keep a pattern of that's occurring in association with certain medications, or if they're trying to exercise and get up, is their blood pressure dropping when they're getting up, causing them that sort of difficulty. So if their blood pressure is dropping, they're not going to tolerate exercise very well, and they'll have that kind of pain. And maybe taking the medicine beforehand, if it's exacerbating their low blood pressure, might be why it's not going as well. So it's really important that they clarify what their blood pressures are. Now, to diagnose orthostatic hypotension, got to make sure that you get that blood pressure and heart rate when you're laying down, and then check your blood pressure and heart rate immediately after, like 2 to 3 minutes in a standing up position. And then a certain number drop without a change in heart rate would tell you that that's orthostatic hypotension from Parkinson's. Yeah.
Have you ever heard of a situation where Ozempic correlation?
Okay, so the question was, have I heard about Ozempic and the onset of Parkinson's? So what Ozempic is, it's a GLP-1 agonist, and so it's used in the diabetes treatment space. Ozempic and those class of medications, there was a lot of excitement in Parkinson's disease, and you would wonder, why are we talking about diabetes medications and Parkinson's disease? Well, in older lab studies that were done in basically petri dishes and test tubes, when they looked at different cells and how they responded to GLP agonists in a test tube, if you exposed neurons to chemicals like MTPT, which is the Parkinson's causing chemical that we use in labs, those neurons would not die in the presence of GLP agonists. So there was a lot of interest in, do GLP agonists help treat or slow down the progression of Parkinson's disease? So that was the original literature behind looking into studies about GLP agonists. So there were some trials that were done in Europe where they used a certain kind of GLP agonist, and they followed patients and they looked and said, hey, some of these patients are not having as severe of symptoms after a certain amount of time on a GLP agonist. Those studies were redone and tried again in tried to be replicated, and there was not the same kind of response that was present in some of those data. So the jury is still out on whether or not GLP-1 agonists are helpful in modifying the trajectory of the disease. But there are some studies that they're looking back on, why did that study not work? And when they looked at the most recent study that was done, they noticed that there was a cohort of patients that weren't losing as much weight as they had lost in one of the other trials. So they're trying to look back and see if there are some patients with Parkinson's with pre-diabetes, and whether they would be ones that would benefit from GLP-1 agonists. So there's research in that space, but right now I don't know enough to be able to tell you that it's going to change the trajectory of disease, or is it just making the prediabetes not as bad, complicating a patient's Parkinson's disease? Mm, yeah.
I read what you were talking about, because it slowed it down. In
Mhm.
my case, I want to keep it up. So
That's okay.
it is what it is. I do have two questions.
Mhm.
Number one is, because it's been part of
Mhm.
I get my muscle here.
Mhm.
What do I do? I mean, is that something that's for ibuprofen or we had on? What do I do for that? The other question is, noticing talk about medication, but have you heard of anything new studies? I did read something earlier. They were just discovered.
Okay. I would have to, so the question for those on Zoom, two parts. One is the patient gets a lot of tremor in the hand and a lot of muscle pain in the part of the hand that is tremoring. And then the second question was about whether there is updates that I'm aware of in regards to Parkinson's and a study referenced in Europe, sorry, Australia. So for the tremor, that muscle soreness that you described is very common. So when tremor is occurring, your joint is moving. And so imagine if you were just writing over and over again and your joint's making multiple movements, that's going to exacerbate pain. Or if you run a mile and you are continuing to move, that's what your tremor is doing. It's running a mile while you're just sitting still. So it's going to get sore. So like you mentioned, things like ibuprofen, Tylenol, heat compress, things that actually help calm down that irritation in the joint and on the muscles itself are helpful. But you don't necessarily want to do that all the time because there are risks to taking things like ibuprofen over and over again. So things like physical therapy, massage, non-medication pharmaceutical options have helped some patients out. Acupuncture have helped some patients out. Just depends on what works for you. Other things are that tightness in the muscle in that same arm that is having tremor could be a sign of rigidity, the stiffness in Parkinson's disease, and it's hard to always distinguish between those two things. And so potentially talking about improving the dopaminergic treatment with things like levodopa or other analogs can help that symptom too. But without examining you, I have a tough time making specific recommendations. But those are the types of considerations to talk about with your doctor for that. And then in regards to updates in research, I don't actually know which study you're talking about.
My son-in-law is he works for pharmaceutical.
Mhm.
So it just came out. He's very, very excited about it. And it's been like 5 to 10 years they've been find something. It's that this made it like that close, more so.
Okay.
I don't know exactly whether it had to be proteins and I was just curious if it's new. I don't know how much. If it's the right direction.
Okay, so you're not the first person to ask me about that, and I got asked about that yesterday with a patient, and I did not know the answer, and so I'm kind of kicking myself for not looking it up last night, but I was just looking at my phone to try and see what it was saying. So In terms of PINK1, what was determined is PINK1 is a gene associated with Parkinson's disease. And a quick plug for the University of Colorado, we have the PD gene study that we're doing to evaluate patients. It's a one-time visit where we do genetic testing as well as genetic counseling to talk about genetic risk factors for Parkinson's disease, so that we can help patients either participate in clinical trials like that PINK1 study that was done in Australia, or other studies such as we have a trial for patients who have GBA mutation-associated Parkinson's disease. These acronyms are all different genes that are variously associated with Parkinson's. And so that study, the PINK1 gene, that was a little bit confusing because it's a gene in the mitochondria. And so it's kind of a breakthrough that, hey, look, this mitochondrial gene has a downstream relationship with the alpha-synuclein protein from the damage that's being done. So let's now start maybe focusing on, should we be targeting that mitochondria? Ooh, that study is helpful in that now we understand why the gene is associated with Parkinson's more so, but it does not necessarily change how I treat patients day to day on the clinical side of things, because I don't have a treatment that directly targets that region. But it's definitely very exciting for the drug development space to try and target those type of mitochondrial interactions.
How about the diet? Can change something, you can add something.
Yeah, there's a lot of research that's being done into the gut microbiome and its associations with Parkinson's disease, and we're learning a lot every day. One of the common gut-related things to look out for that can affect medication absorption and medication effect is H. pylori. So that's sometimes something that pops up in Parkinson's patients that makes treatment not go as well. So being sure that if you do have peptic ulcer disease or H. pylori infections, to talk with a GI doctor to get those treated and taken care of. Other things directly linking what sort of dietary recommendations, whether things like a keto diet or whether carbs or whether fats, what is it in diets that are exacerbating things? And all we really know right now is trying to maintain a health-focused diet, potentially the Mediterranean diet, that helps with optimizing one's cardiovascular disease risk factors and diabetic risk factors to prevent onset of heart disease and diabetes, helps with patients from developing cardiovascular outcomes. So like small strokes in the right part of the brain, or small little diabetic changes in the part of the brain that contribute to worsening Parkinson's outcomes. So maintaining those healthy diets, Mediterranean diet is the one that there's been some research study, and that study was done in combination with that exercise recommendation I had talked about in patients preventing Alzheimer's / cognitive difficulty. So that's one option.
Questions from Kathy, who's online.
Yeah.
So the first one is, what can be helpful for a forward shoulder and neck stance when walking?
Okay. So for a forward shoulder and neck stance, that's going to be that posture, that stoop posture that comes up with Parkinson's disease. And that is variably responsive to medications. So some patients can be on their dopaminergic medications and notice that they're able to stand up straighter and remind themselves to stand up straighter. So that's one option. But the other thing is that can sometimes be dystonia. And sometimes medications can exacerbate or worsen that. So keeping a diary and keeping track of when that symptom comes up in association with your medications can help with figuring out whether it's responsive or not. Other things that can be done for shoulder positions and head neck positions are that dystonia that I had talked about. So you can get into some cervical dystonia where the head wants to turn or pull in a certain direction. And we treat that like we would treat just run-of-the-mill cervical dystonia. And the #1 treatment for that is Botox injections that can help. So talking with your doctor about if they think you have dystonia is an option. That Botox could help with weakening the muscles that are pulling the head in a certain position to help relax that. Though I will note that if it is the forward head position and the forward head neck position, that's one of the more difficult and most difficult positions to treat with Botox, because those muscles that pull the neck forward are really in front and close by to some of the swallowing centers. And so it can exacerbate swallowing difficulties to do Botox for that. But again, talk with your doctor about those options.
And then her second question is, are the movement doctors at Andrews taking new patients? Our neurologist just left where we had been going to find a new doctor.
Yes, we are taking new patients. I have spots scheduled every week to see new patients in my clinic at Anschutz as well. So for those who are not familiar with how the fellow resident kind of system works, so in medical training, you go through residency, internship, then residency, and then once you finish residency, you're a full-fledged whatever kind of doctor. So I'm a full-fledged neurologist. And then I'm now in my fellowship training, and fellowship training is optional after becoming a neurologist to subspecialize. So I'm getting additional training right now in movement disorders and seeing movement disorders patients at Anschutz. And so it's a 2-year fellowship. The first year is a lot of clinical, and the second year I can do a little bit more research, focusing in on some of those deep brain stimulation things that I was interested in.
So you are taking it. And then could you, I'll text her your spelling, the spelling of your name also, but could you just?
Yeah, I'm Vinay Tallavajhala. Last name is Tallavajhala. And then I go by Dr. Sonny. You know, they don't have a card for me yet.
Okay.
Was that all the questions from online? Yeah, go ahead.
I've been diagnosed with functional movement disorder, but I've noticed my tremors in the last 2 years. My original tremor was just my head going back. It would do it probably 8 hours a day. And then 2 years ago, my leg, and that was my first system, was my leg.
Sure.
My right leg was moved. And that started in my late 30s. And then it would disappear. But 2 years ago, everything, my arms, my legs, it was like nonstop for hours. And now I have a lot of, I don't know, they call it a headache, but it's just a lot of pain in my temple area and my back here.
Sure.
And you can't get any therapies here, and nothing seems to be just going around in circles.
Yeah.
And it's getting so much worse.
It's always important. So the question was, a patient has functional movement disorder diagnosis and is having some worsening symptoms over the past 2 years without being able to get therapy in the area. And so with a diagnosis of functional movement disorder, it's always important to keep in mind that new diagnoses can pop up along the way, and following up and getting reevaluation is always important if you think you're having some new symptoms that are different from your prior functional movement disorder. So definitely talk to your doctor about getting a reevaluation with a movement disorder specialist, okay? Yeah.
I had turning.
Yeah.
And then.
So-
what else?
Yeah, I would definitely make sure you're going in to get reevaluated and touch base if you got diagnosed more than 2 years ago.
Well, the
Mhm.
first one, the first neurologist, but it was during right before COVID, so nothing happened. He called it conversion disorder.
Yeah, so go ahead and I would definitely go back to get a second opinion or just see what's going on with symptoms. Okay. Yes.
That when you, what happens to the synaptic point, right? And the message doesn't cross over on the dopamine. And then the protein that covers it up. I was reading one of them online research thing that's going on. Protein is settling in on the dopamine axis area. This message then doesn't go across the protein.
Okay, so the question was, what's happening with the protein and the dopamine in the brain that's causing difficulty in Parkinson's disease? And so the way the protein interaction works is that the abnormal protein in Parkinson's disease is called alpha-synuclein, and then the generic name for that is the Lewy body. And so the Lewy body, it accumulates in certain neurons in certain Lewy body conditions, such as Parkinson's disease, REM sleep behavior disorder, multiple system atrophy, Lewy body dementia, and pure autonomic failure. Those are the 5 alpha-synucleins or Lewy body diseases. Now, when the Lewy body deposits in the movement centers of the brain, you have Parkinson's disease. When those Lewy bodies deposit in the memory centers of the brain first, you have Lewy body dementia, and then you can have an overlap between the two. In terms of the Lewy bodies, when it deposits in those movement centers of the brain, it deposits here in the substantia nigra, and you have degeneration of those substantia nigra neurons. So the brain makes less dopamine over time. And so as the brain is making less dopamine, the dopamine receptor is upregulated, and you get a little bit more of the dopamine receptors, but you don't have enough dopamine there to bind to those dopamine receptors. So the fact that you don't have as much dopamine to bind to those receptors makes it so that the symptoms of Parkinson's come out. And it's the fact that there's that insufficient dopamine to tell the other side what to do and what's going on. Does that answer the question?
Close enough for me.
Okay. Okay.
Thank you so much.